Hello and welcome. Before we start this video, this is a reminder to subscribe to this channel, to comment, share and press the bell icon for notification of further videos. This video is about hypothyroidism and pregnancy. We will talk about a patient who will be primarily managed by the obstetrician in consultation with the endocrinologist. Obstetricians should have a very high index of suspicion for detecting cases and for early administration of thyroxine until the patient is seen by an endocrinologist. The obstetrician will also have the responsibility to follow up with repeat levels during pregnancy. Thyroid disorders are the second most common endocrinological disorders found in pregnancy, the most common being diabetes. Overt hypothyroidism is estimated to occur in 0.3 to 0.5% of pregnancies. Subclinical hypothyroidism, which is hidden, appears to occur in 2 to 3%, and hyperthyroidism is present in 0.1 to 0.4%. Autoimmune thyroid dysfunctions remain a common cause of both hypothyroidism and hyperthyroidism in pregnant women. Early in pregnancy, in the mother, the thyroid levels will start to decrease, and this is because of the effect of human chorionic gonadotropin on TSH levels. As pregnancy progresses, the TSH levels will gradually rise back to normal levels. The thyroid hormones, free thyroxine and free T3, also remain relatively stable or may even increase slightly during pregnancy due to increased production by the thyroid gland. So the thyroid hormone secretion is essential for fetal development and for the metabolic demands. So the pregnancy-related hormonal changes, especially the HCG, can lead to mild thyroid enlargement in pregnant women. This is usually a physiological response and not necessarily indicative of thyroid disorder. However, adequate iodine intake is crucial for thyroid hormone synthesis, and during pregnancy, the iodine requirements will increase due to the needs of the developing fetus. The fetus does not require iodine initially, but the mother does require iodine to make sure that her thyroxine levels remain within normal levels. However, when the thyroid gland starts to develop in the fetus towards the end of the first trimester, the fetus will also now require iodine levels to make thyroxine. So during the first trimester of pregnancy, the fetal thyroid gland is not yet fully functional. So the fetus relies entirely on maternal thyroid hormones for brain growth. If the mother is not producing sufficient thyroid hormone, then this can lead to brain and neural tube defects in the fetus. The thyroid hormones also play a role in the development of various fetal organs, including the heart, the lungs, and the liver. Proper levels are crucial to ensure healthy organ formation. So we have to ask ourselves the question that how do thyroid function tests results change during pregnancy. To meet the challenge of increased metabolic needs during pregnancy, the thyroid gland adapts through changes in thyroid hormone economy and in the regulation of the hypothalamic pituitary thyroid axis. During pregnancy, women will have slightly lower serum TSH levels as compared to before pregnancy. But these are still within the normal limits for normal women. And the serum FT4 and T4 concentrations will also remain the same. If supposing a woman is pregnant and her hypothyroidism has not been detected, or it has been detected but the woman is not receiving adequate treatment, then she will have complications which will include microcytic anemia, preeclampsia, placental abruption, postpartum hemorrhage, cardiac dysfunction, and miscarriages. The fetus, on the other hand, if the mother does not get treated properly, then the fetus will result in many complications which will extend into the neonatal period, and these include prematurity, low birth weight, congenital anomalies, stillbirth, and poor neuropsychological development. Now we have to understand the meaning of overt hypothyroidism. So overt hypothyroidism means when the patient has symptoms of hypothyroidism, and usually she has also been diagnosed with hypothyroidism. On the other hand, subclinical hypothyroidism is when the woman may have certain risk factors such as history of miscarriages, history of stillbirth, and the symptoms are not very prominent, but she may be harboring a subclinical hypothyroid state. So let us talk about maternal clinical presentation in overt hypothyroidism. Symptoms will include lethargy, weight increase, and constipation. And patients frequently report having cold intolerance, stiffness, muscle cramping, carpal tunnel syndrome, dry hair, skin, and a deepened voice. Now, as you can see from the symptoms above, these symptoms are very similar to those which are experienced by women in normal pregnancies, and so diagnosis may be difficult. In subclinical hypothyroidism, which may affect 2 to 3% of women in pregnancy, the symptoms may be vague and non-specific, and the diagnosis will be based on normal levels of free thyroxine and elevated TSH levels. What about general examination in cases where overt hypothyroidism is present? Patients will appear to have slowed speech and movement. They may be forgetful and exhibit difficulty with concentration. And eye examination may reveal periorbital puffiness, a large tongue, an expressionless face in severe disease. The skin will be pale, dry, and yellowish. Hair is thin, brittle, and sparse. An examination of the extremities may reveal non-pitting edema and hyporeflexia with prolongation of the relaxation phase of the reflex response. On systemic examination, we may find that the auditory acuity is decreased, so they may not be able to hear as well. Thyroid gland may have a goiter, and if this is associated with Hashimoto thyroiditis, it will be firm, diffusely enlarged, and usually painless to palpation. Or the thyroid gland may be normal and not palpable. On examination of the heart, there may be a normal or a low heart rate. If the heart is enlarged, it will be dilated, and pericardial effusion is present in very severe cases. Bowel sounds may be decreased or absent, and paralytic ileus has been reported in severe cases of hyperthyroidism. If you see a patient with either subclinical hypothyroidism or with overt hypothyroidism, there may be some overlapping of symptoms with other conditions such as, and this is the differential diagnosis. So there's a group of disorders which are which is included in thyroid disorders, and this includes primary, secondary, or subclinical hypothyroidism. So that comes as part of the differential diagnosis. But apart from that, there may be some thyroiditis, which is usually seen in the postpartum period, and it may be silent thyroiditis or it may be severe thyroiditis. Or hyperthyroidism. Depression can also mimic the symptoms because the patients may complain of fatigue, low energy, and changes in mood. It is essential to differentiate between the two to ensure proper treatment. Chronic fatigue syndrome. This condition involves persistent fatigue that is not alleviated by rest and can mimic some symptoms of hypothyroidism. So this is a diagnosis of chronic fatigue syndrome can only be made by an internist and not by a gynecologist, and it is a diagnosis by exclusion. Anemia characterized by low red blood cell count or low hemoglobin levels can also lead to fatigue and weakness, and these are common symptoms in hypothyroidism. Fibromyalgia, which is a chronic disorder characterized by widespread musculoskeletal pain, fatigue, and sleep disturbances. The symptoms can overlap, and again, this diagnosis would be made by an internist and not by a gynecologist. Chronic kidney disease and menopause. So it's important to understand that there are certain gynecological conditions which may mimic the symptoms of hypothyroidism, and there are some medical conditions which are quite serious, like chronic kidney disease or like severe or like hypothyroidism or hyperthyroidism. And then there are certain diseases which are more like psychological, for example, depression. How do we decide what lab studies we will do in pregnant patients with hypothyroidism? In primary hypothyroidism, the TSH levels are elevated and the FT4 value or the FT4 index will be low. But in subclinical hypothyroidism, the FT4 values will be normal and the TSH level will be elevated. We also test for anti-thyroid peroxidase antibody levels and anti-thyroglobulin antibody levels. So anti-thyroid peroxidase antibody levels should be measured in pregnant women with possible hypothyroidism to determine if Hashimoto thyroiditis is the cause. Again, this is a domain for the internist or for the endocrinologist. In addition to the thyroid studies, patients also need to have other studies done because the thyroxine levels in the body can affect metabolic function as well as they can affect the liver function. So a complete blood picture and liver function test should be conducted, and anemia is observed in as many as 30 to 40% of patients with hypothyroidism. And this is above the general levels which are present in our population, and erythropoiesis will be decreased in hypothyroidism. Similarly, concomitant vitamin B12 or folic acid deficiency should be considered if the anemia is macrocytic, but leukocyte and platelet counts are usually normal. There are many imaging studies that can be performed in thyroid diseases. But when we are, and these include ultrasonography, CT scanning, MRI, and radioactive iodine uptake testing. However, during pregnancy, ultrasonography is considered a safe test, and this is only done if we find a nodule in the thyroid gland, and then this test will help us to differentiate a cystic nodule from a solid nodule for further referral to a surgeon, ENT surgeon. On the other hand, it is important to remember that radioactive iodine uptake testing is contraindicated in pregnancy because this radioactive material can enter the fetal circulation and can destroy the fetal thyroid gland, leading to permanent hypothyroidism in the baby. The medical management of hypothyroidism in pregnant patients is a combination of treatment by the obstetrician and by the endocrinologist. So obstetricians should have awareness about the medical management once it has been started. They should also have a very high index of suspicion for detecting cases and for early administration of thyroxine until the patient is seen by endocrinologist. And they should also be responsible for doing repeat levels during pregnancy because they will be seeing the patient more frequently as compared to the endocrinologist. Unlike healthy women, those with pre-existing hypothyroidism or subclinical hypothyroidism are unable to increase thyroid hormone production during pregnancy. So hypothyroid women who are newly pregnant should preemptively increase their thyroid hormone dose by approximately 30% and notify their clinician promptly. So if a patient is taking 10 tablets in a week, then she has to increase 3 tablets on a minimum. And so you have to work it out that what level of hormones you will increase orally in the patient until she is seen by endocrinologist. So the goal of treatment is to normalize maternal TSH levels using synthetic thyroxine. If you are seeing the patient for the first time, then a full replacement dose of 1.6 to 2 micrograms per kilogram per day should be started at the time of diagnosis. And in addition to that, you can also add supplemental iodine during pregnancy and during lactation of approximately 250 micrograms per day. The dosage of thyroid hormone should be increased at 4 to 6 weeks of gestation, and an increase of 25 to 30% will be required. This is because the increased requirement for thyroid hormone, that is endogenous or exogenous thyroxine, occurs as early as 4 to 6 weeks of pregnancy and gradually increases through 16 to 20 weeks of pregnancy and thereafter plateaus until it is a time for delivery. The outcome of pregnancies or the prognosis is affected by autoimmune thyroid disease depending on the degree of metabolic control. If the woman becomes euthyroid because of her treatment, she can expect a satisfactory outcome of her pregnancy. And with close follow-up postpartum, medical therapy can be adjusted to ensure a euthyroid state to ensure a good prognosis. Patients and their families need to be educated if hypothyroidism is diagnosed in the pregnant patients. And the most important aspect of this counseling or this education is to inform them of the adverse effect of hypothyroidism on the fetus. So if the medical therapy is not taken adequately, then the fetus will be affected. Or if the medical therapy is not taken at all, then the fetus will be affected. Not only is it important to take the medication as it is prescribed, but it is also important to keep on testing in the laboratory to make sure that the patient's needs are met by adjusting the dose. So an important question can be that should all pregnant patients be screened for hypothyroidism? Considering the deleterious and the harmful effects of hypothyroidism on the fetus and also on the mother. So currently, the American College of Obstetricians and Gynecologists does not recommend universal screening for thyroid disease in pregnant women, but screening is recommended for those who are at increased risk. And this includes a group of women who either have a personal history or a family history of thyroid disease, or who have type 1 diabetes mellitus, or who have symptoms suggestive of thyroid disease, or who have a past history of poor pregnancy outcome, or if there is the presence of significant goiter or distinct thyroid nodules. If it's a mildly enlarged thyroid gland during pregnancy, then this does not warrant screening, and if there are no symptoms. With this, we come to the end of our video. If you like this video, please subscribe, press the like button, comment, share, and press the bell icon for information about upcoming videos. Thank you and goodbye.